Hi, everyone. This is Lynn Crawford with Hope Dementia Support, and I am honored to introduce you to Dr. Lynda Tang of the Vancouver Clinic. Dr. Tang runs the palliative care program there, and I'm going to let her tell you a little bit about her background. And also, we will be able to periodically put things in the chat when you're requested to, so we can make this a more interactive than we normally are. So, Dr. Tang.
Hello, I'm Lynda Tang. I'm a palliative medicine physician. I came to Vancouver in 2015 uh, from the East Coast, and I've just established my practice here, my family here. I built my family here, and so just great to be a part of the community. I am clinic-based, so I don't go to homes yet, and I don't go to the hospital anymore. So it's all video visits and in the office palliative medicine. I don't like to talk about myself, so I actually want to open up the session by asking who you are. I'd love for you all to put in the chat, who is all here? Are you a daughter, a son, a spouse, a loyal, caring caregiver? Are you the patient? Let me know who is here so then I can get a sense of who I'm talking to. I think the way this is set up, I don't get to see the 18 faces.
Okay.
Okay, welcome, Battleground. Yeah, we wear multiple hats. You are wearing the caregiver hat, you're wearing the child of the parent. Um, yep, you can be the spouse, you can be the caregiver. Sometimes those hats get mixed up and you're like, which hat am I wearing? And it can be overwhelming. There's a sister, a facilitator, care for my mother. So another child. So multiple hats, right? Professional hat, family hat, caregiver hat. Mhm. So it's sounding like people have more than one identity, more than one hat that they're carrying. And this is one of those diseases that is pretty adjacent to the caregiver and the family, more so than any other disease out there. I would never rate one disease over another, but this is a harder disease because it's every day, every minute. You don't rest from being a caregiver. You don't rest with dementia. Right, another spouse. All right. Well, thank you so much. Continue introducing yourself, of course. Yeah, so sometimes we are moved to a higher purpose or a different purpose after we've had our own personal challenges or experiences. And sometimes it births new things that we can give others from the experiences that we've shared and learned. So thank you for um, giving a part of you and things that you've learned from your own experiences. The next question I'd like to ask everyone is, why are you here today? Why would you give me your dinner time? Why would you put things on pause at 6:30? I mean, you could be watching a movie. There's like really nice weather outside. You could be hiking. So what brings you in to share this hour and a half with me? What are you interested in learning, hearing more about, hearing about again? What would be of use to you? We do have an agenda, but it would be nice to kind of sample where we should focus our material and give more presentation platform to certain topics. Yeah, people want options. That's pretty common. They want to know what options are available out there, what services are out there. And sometimes options are, what are options for me? What can I do for myself so that it is not a sprint. Dementia is not a sprint. It is a freaking marathon. Looking to learn what might be needed in the future. Yeah, future planning, right? We got short-term goals, got long-term goals. People in my group are facing decisions, more about palliative medicine, stage 3, looking at the future. Okay, we have a little bit of everything. Um, yeah, Judy, thank you so much for bringing that up. My my like social like anxiety, if you can believe that, is why would anybody care what I have to say? They already heard it before. And Lynn has been so gracious to say people want to hear it again. And I think that's the bias. I'm like, it's in my brain. I see people all day. And then I'm like, why would they want to hear it again? And so thank you for telling me that you've attended before, and it's just good to hear it again. And sometimes people are in a different stage the following year. Expanding knowledge, planning for the future. Wow, Janet, thanks for sharing such a personal side of your family to us. Thank you. I need to hear multiple things multiple times, and it resonates differently depending on what's going on. I hear you. Sometimes I hear instructions to do something, and then I hear it differently just because of the time of the day and who's talking to me. Learning what is changing for those with memory disorder, the direction of treatment. Wonderful, wonderful. Keep it coming through, and Lynn will be my person to kind of navigate and guide, and we'll pivot. Lynn, I'm not sure if we are asking for questions kind of like rolling, or if we ask questions at the end. I don't remember how we did it last year, but I thought what we did last year was great. I think everybody walked away with something that they could like take to
I
the
am
bank.
comfortable doing it with however you like it.
Okay.
So if you'd rather hold till the end, or people can, what we typically do is ask people to put their questions in the chat as they come to them.
Okay.
And then we wait till the end, but we can certainly um, answer them as they come through, whichever you prefer.
Okay. So I'm going to ask that people pile in questions as they come to you, because for me, if I don't type it, I'll forget. So if you want to write it down, put it in the chat, and I will entrust Lynn with making sure that when the topic comes up, the question in the chat is acknowledged. And so we'll be bookmarking those for you, and we will not answer any of your questions. I think we have enough time to give you more than you actually want. All right, so I do have a slide deck that I can jump around. So people said they're willing to learn, and someone actually specifically said, I want to hear about palliative medicine. There was some people who said they've had experience with hospice. So I'm going to summarize it in this beautiful animation that I made. So hopefully you all can see this. Lynn, is everything okay? Can you
Yes,
see this?
everything's
Okay.
fine.
So this is a continuum of when you're born to when you naturally die. I think of it as time, there's a disease progression, it's your age, however you want to look at it. And I am not a big sports fan, but I do like a little basketball here and there. So I think of it as when you were born, you're given a jersey, okay? And you belong to the blue team. And the blue team's goal is we're going to diagnose, we're going to treat, and we're going to cure whatever ails you. And so you might be familiar with the blue jersey team. They are your primary care practitioner. They might be a neurologist that you see, a heart doctor, lung doctor, maybe geriatrics even. Like just list all the people that either your loved one sees or even you. Blue jersey team. The urgent care is also on the blue team, the ER and the hospital. So basically everything that you've used up to this point or your loved one has used up to this point is all blue jersey people. Palliative medicine is a specialty. There's a fellowship, and it's another doctor or practitioner on the blue team. And what do they do? Well, dementia, end stage COPD, heart failure that's complex. So we don't take care of like stable people, we take care of like advanced chronically ill patients. Cancer comes in there sometimes. And then we look at the symptoms, right? So with dementia, it might be restlessness, agitation, anxiety, um, behavioral issues. That could be physical, that could be emotional damage, constipation, depression, loss of appetite, any symptom that comes with the disease, we help manage so that that person, that patient can have better quality of life, which is basically saying, can I help you move through the day? And by helping you, I'm helping your caregiver. And then, of course, this is a very deep memory lesson. One of my patients taught me is the window of time to talk to the patient who has dementia starts closing as time goes on. And so it can cause a lot of distress to the caregiver and the family if the medical team comes to you and says, hey, we found this mass. You should have a colonoscopy, maybe surgery. What do you think mom, dad, sister, brother, spouse would want? And then hopefully you're not standing there thinking, I never asked them. I actually don't know. This is too hard for me to decide for them. And so we want you to be equipped and confident that you know what the goals are, what the advanced care planning decisions are. Other goals are, wow, this patient's had a lot of aspiration pneumonia. They've been in the hospital a bunch of times. What do we do next? How do we navigate the roadmap? And then we can talk about quality of life. Oftentimes I'm asking people, so what do you think your mother's quality of life right now is? Like, is she happy with how things are? And some people will say, oh, she doesn't recognize us, but she's very pleasant and we eat with her and we play. I think she's doing fine. And then some other people will come and they'll say, I'm not sure that this is what she signed up for. It's been really hard. So we talk about those things in palliative medicine. We might even talk to you about a higher level of care if they're living at home and it's just getting really unsafe for them, for you. And we need to talk about the next level of care. We can help guide you through that transition. All right, so that's palliative medicine. This is the patient. So this is their life, which means they come to palliative care when they're done and ready. I'm not the gatekeeper, but you all could be advocates and tell your doctors, practitioners. We'd love to have a palliative care specialist join the team, give them a jersey. We'd love for them to hike with us on this trail because we know that we're going to need some help. And it could be help with documentation, it could be help with symptoms, it could be help with coordination of care. So that's the patient showing up. They're going to walk through their time frame with dementia. Eventually, towards the natural last 6 months of the disease, they have an option to change teams. They can exchange their blue jersey for the orange jersey. It's literally changing teams because insurance will only cover one team at a time. So you've got to make a choice. So if you're good and ready and your goal is comfort focused, end of life transition, no more colonoscopies, don't care about clinical trials, don't touch me with that scalpel, I don't want to go back to the hospital, I want a comfortable, natural end of life. You definitely need the team that specializes in that. So that's called the hospice team. So hopefully you can appreciate that there are two teams and then you just transition over to that team. Do you have to? No. You can wear the blue jersey, but it's not a great look when you're dying wearing the blue jersey. You should wear the orange jersey. It brings out the color, it's comfortable, it's in style. We hope that you don't keep wearing the blue jersey. I don't know if the chat box has any questions on this diagram. If you
We
do,
have a hand up, and I'm just going to let her ask her question.
sure.
Dorothy, can you unmute? And then you can ask your question.
Oh, I don't have one right now.
Oh, your hand was up.
My hand. Oh, you could see me.
No, it's just a little cartoon hand.
Yeah. No.
All
Okay.
right.
We'll lower your hand.
I don't have it up. What do I need to do?
Oh, I just
It's
lowered it.
down now.
Fine. It's
Okay.
fine. You're good.
It's fine. Okay.
Okay.
All right. We'll move along if there aren't questions in the chat box. All right. All right.
Let's see. Here's one. Is hospice care always outside the hospital environment?
No. Ideally, if attending this lecture, if with a bona fide palliative team, you should secure hospice outside of the hospital. Let's say that you didn't. Hospice inside the hospital could be, I'm having a heart attack, I'm having shortness of breath, I'm having a seizure, I'm declining, and I'm unstable, and I'm not going to make it home. Then they might do hospice for you at the ER or in the hospital. And I don't know about you, but if I ask 10 people, maybe 9.5 people will say, I don't want to die in a hospital. And then 0.5 will say, I think it would be fine to die in the hospital. So that's how that happens. Good question.
And then we have somebody that wants you to jump back to palliative care.
Okay. Palliative care has a couple of models. Model number one, we're in the hospital, we run around, we do consults like a cardiologist. We get paid, we go see the patient. And we only stay in the hospital, we don't have an office. Some models have office as well as hospital, so they go back and forth. Very crazy. Some models are only clinic, that's me. Some models are only run by nurses and not practitioners, so they make phone calls, they make house visits, but they don't write orders because there's no practitioner overseeing the nurses. Some models have a practitioner that will make house calls. They drive to the house and they see the patient. And they don't do the hospital and they don't have a clinic. They just ride in their car, go to the person's house, they're on call, and they take care of the patient, just like an office visit, but they go to the house. I hope that answers the question.
I think so. And I think she'll tell you if it doesn't.
Okay. Really good question. And those different models exist in Clark County depending on what you need and which company you're looking at. Which is if you need that, we can dive into that at the end, or I can give you a handout. Knowing what model you're looking for is important.
We do have a question that maybe now is appropriate time. It's one of the reasons that someone is here is to learn more about what is changing for those with memory disorders, the direction of treatment.
I don't know if this question is talking about medications or the services available. So please clarify the question.
My perception is that it is the services available.
Okay. Do we know who asked that question?
I do.
Okay. Let's
So,
get that person to
so
clarify.
Marilyn, you can clarify for us. And then Rosemary says, um, a further question related to palliative care is what would trigger choosing palliative care versus just a regular doctor's care?
So while we're getting clarification on the new advancements, your primary care team will still be your doctor practitioner. You don't switch anything. Just like if you have a pulmonologist, you don't get rid of your primary care. So how is it different? Your primary care has a lot of work to do. They're going to manage your hypertension, your diabetes, your annual wellness visit, your cholesterol, your vitamins, your wellness, your mental health. They do like all of that stuff. If you have a migraine, if you have pneumonia, you're calling them for chest x-rays, for opinion. A palliative medicine physician can do those things, but they're more trained to do the seriously sick people. And so some of those seriously sick people are close to hospice or they are upstream from hospice. And so it requires a different skill set. It requires office visits that are 30 to 60 minutes long, not 15 or 20 minutes. If you're getting palliative medicine in the hospital, usually those conversations are a little bit more pushy. They're a little bit more aggressive, which is, are we going to withdraw support? Are we going to get readmitted over and over again because nothing is changing, things are only getting worse? So those conversations are not primary care led. Those are very much like, let me guide you, let me help you see the map. There's some blind spots in different areas that have not been explained to you for you to see the whole picture. We have to do that so that you and your family can make the best decision that makes sense for your quality of life and moving forward.
We have a question. Do patients have to have it written in their advance directive that they don't want to be force spoon fed and they want to voluntarily stop eating and drinking and get palliative care at that point?
That is a really multi-layered question. I believe that we will cover that under advanced care planning. The reason why this question is so complex is you're talking about voluntary cessation of eating and drinking, which is a adjacent option to death with dignity. And then the other layer of complexity is you're asking if you need palliative medicine. And the technicality is you may need it, but if you don't get it or want it, nothing's going to come to you. So your primary care team could say, I need you to see a pulmonologist. And you might say, I don't think so. And you have the right to say that. So it's a rather complex question, and I think the answer will present itself as we go through more of the information, but it is a very good one.
Thank you.
Others before we go on? Did I miss anything?
Not so far. We're good.
Okay. Yeah, let's bookmark that because pieces of it are gonna come later.
Okay.
All right, so advanced care planning. There is a treatment paradigm shift. So if you're talking about what advances are happening, if you're talking about meds, yes, there are some new meds. If you're talking about like approaches to dementia, this is one of them. The idea of advanced care planning used to be very much paper related. Like, do you have a will? Do you have a do not resuscitate? And the paradigm shift across the United States, and especially in Washington as of 2016, is the plan with the people and the conversation and the progression of the disease over time. So we're moving away from paper. Paper's good. Paper's not good at 3 in the morning in the hospital. No one's going to find them. So we're focusing advanced care planning on the people, and that means you. the people that are in this room. So it's broken up into 3 categories. You can have an advanced directive, you can have a pulsed form, that really nice neon fluorescent green form. And then you could have a goals of care or care preferences discussion. All of this falls under advanced care planning. The advanced directive is an actual piece of paper. The pulse is a piece of paper. The goals of care, that's the conversation. That is the conversation over time that involves people that care about you, that understand your wishes. I can take people to the bank. I may not be able to find documentation when I need it. And so I can always call a person's family member or friend. So it's so much more valuable that the people that are sitting in this room, they have the information for their orange team and for the blue team. But we are a legal society. So if you are going to fill out paperwork, you could do a living will, you could do a healthcare directive, and you could do a power of attorney for healthcare decision making. You should all have these. A healthcare directive and a power of attorney, you can have that starting at 18 because it has nothing to do with advanced disease. It's just appointing someone to be your spokesperson. And a healthcare directive is basically saying if I am in a vegetative, dire terminal state with no recovery, yes, keep me alive. No, don't keep me alive. So anybody at 18 can actually answer that. The living will can name a financial or a medical power of attorney embedded in the language of the living will. Hopefully this is clear as mud. This is why you need a specialist to kind of help you navigate this. Lawyers cost way too much. I promise. Like you'll save money if you go see your doctor instead of going to the lawyer. And apologies for anybody who is a lawyer or is married to one or knows one. All right, so we already talked about advanced care planning, and a way to kind of think about it is learn about it, choose, talk to the people. What if something happens to me? What is it that I want? What is it that I don't want? Then as you get closer to more complexity and sickness, then it's like, okay, I have CHF, I have dementia. What do I understand about where it's going? What stage am I at? What do I fear? What do I value? What are trade-offs? What is really important? And it gets more specific. What if this happens? What if I get pneumonia again? What if I have another heart attack and I have dementia? And then the decisions is that planning process people that I'm telling you, which is specific to the moment. And it's guided by all this stuff that you've done over time to help the son, the daughter, the spouse, the caregiver to say, we know exactly what this person wants. And this is happening now, and this is what we want to do next. So that's why it is a conversation over time, incrementally. It shouldn't just be, hey, we're in the ICU, let's have that discussion now. It's just not very ideal. And it's definitely not ideal when your dementia loved one is no longer present and they can't give you a clear idea. I have some really sad stories about that. And if we have time at the end, just type in the chat box or raise your hand and I'll tell you the story. I mean, stories just stick in your mind when they're, imprinting. Okay, this is just a representation of what I just said in the triangle. This is the lifespan of a person. And of course, as we know, with disease, we have a downward trend of your function and ability. So you can think of this as birth to death. You should be doing this over the process of your entire life, starting at 18 years of age. So if you were to break it up into the seasons of your life or decades of your life, then if you are healthy or you have like stable chronic disease, name a power of attorney, right? You get into a car, something could happen. You need somebody to be that recorder. If you have a serious illness, which is dementia, or you have complicated dementia and things are getting just a little bit more tricky, you definitely want to have a serious illness conversation or goals of care with your primary, with your neurologist, with your Med doctor, with your chaplain, with your social worker, et cetera, et cetera, et cetera. Only in the last 2 years, or in a very specific case, would the pulse actually be legally, ethically used. It is not meant for people just because I turned 65. That is incorrect. It's people in the last 2 years of their life for which CPR would be more damaging than helpful. And so you want to be able to complete that do not resuscitate form with the clinician. Hopefully that's not at the ICU and chaos is happening. We want to do it in a nice, comfortable, relaxed, not pressured time and space so that the truth comes out and people aren't being pressured or bullied or persuaded into either direction, more treatment or less treatment. It happens both ways. Questions about this? Don't let the colors and all the words scare you. Just think of it as find the people, talk about the plans. All right. So once again, just to summarize, get your power of attorney, get your healthcare directive, continue the conversation. If you want to have a living will, great, get one. Keep on talking. That's why the conversations keep on talking, keep on talking. And only towards status and end of life and 2 years, give or take, frailty, then you do the pulse work. So that's the continuum. All right. This is the slide about hospice. Some of you in the chat talked about the stage at which your family member is having dementia. So there are 7 stages, and then there's little stages within 6 and 7. 7C as in cat is the stage at which you enter and are eligible for hospice. You can change jerseys at that time. The problem with this is that some people don't actually get to 7C. They may die from their heart or their lungs or cancer before they get to 7C. Depending on who you ask, that can be very merciful. And then other people say, well, I don't have any diseases. The only thing I have is dementia. Then you're waiting for 7C to happen before you hit that 6-month mark and you are eligible for dementia. It's never this clean and it's never this straightforward. I'll tell you that much. I think the slides will be available to the audience, Lynn. We did that last time, I believe.
Yes, it will be.
Okay.
Thank you.
Yeah.
As long as you let
So-
me.
Oh, of course. By all means. So if you're interested in this, we'll give you the slides and then you can look at them. Questions about things up to this point before I go on to the next thing? So the next section is answering the question from the chat of what do I expect? What is the future going to look like? This functional assessment scale can tell you this is the first stage, second stage, third stage, fourth. If you're in 4, you have to look forward to 5. If you're in 5, start thinking about 6. And then once you are in the incontinence space, you definitely want to make sure that plans are talked about, wishes are documented, family is on board, and then get ready for hospice. Get ready for a natural, comfortable, easy transition as best as you can. All right. So I mentioned early on in the chat and talk that it could be a blessing and it could be whatever you want it to be. The reason why dementia is an everyday, all day, burdensome disease is because how slow it progresses over time. Compared to cancer and other diseases, this is what dementia looks like. It's frailty, it's memory loss, it goes up, it goes down. I mean, it just kind of like grass growing, slow dwindling. If you go to the hospital for a heart attack or anything acute, it makes this dwindling much faster and more interesting. Um, so examples are your loved one already has confusion. Being hospitalized for whatever is going to make that confusion worse. And then when they leave the hospital, that confusion kind of persists for a little bit, or it becomes the new normal for your loved one. So that's why this is a very difficult disease to stand by. Um, it's a tough one. It's tough, different than cancer. It's tough, different than diabetes. It's just tough. So as I mentioned before, if you're lucky or unlucky to only have dementia, then that's how your trajectory is going to go. If you are unlucky and you happen to also have heart failure, COPD, heart attacks, anything else, this is what the trajectory looks like. Each of these divots down here, the red, indicates an admission to the hospital, right? So you're hanging out, you go to the hospital, you dip down in function, you go to rehab to try to get back up, only to then dip down again because you went to the ER. If you go to the ICU, that dip is even lower because you're losing a lot of ground. And then with a dementia patient, that really intensifies their dementia. It has the ability to like uncork what was underlying all along. So some people who haven't been diagnosed with dementia, they'll have a episode at the hospital and then they'll come home and the family member will say to me, after that pneumonia, seizure, hospitalization, I've just noticed that my dad's memory has just been worse. And it's like he went into dementia. And then my response is it was always there, but the hospitalization uncorked it and just unmasked it, and then it just came out. But it was always there. So that's why these graphs are so important, and this is why the hospital doctors and clinicians are so intent on making sure that that dementia doesn't get worse because people are going back and forth to the hospital. There's a cost to all of this. Questions about those graphs?
So on on the previous graph, the frailty one, where you would see no, I guess the one prior to that, where you would see hospitalization. Sorry to make you go back so far.
This one or this
No,
one?
the one, is it the first one?
This one?
Probably, yes. Yeah, no, that one. So where you see those dips,
Mm-hmm.
and then you see that their level is lower
Mm-hmm.
and lower with each hospitalization. Could you speak to that a little bit as to what happens to
It's
that
this one.
individual?
It's
Yeah,
this one.
it's like this one. Yeah. Yeah.
Okay. So an example of this would be a patient who comes to me, 80 years old. We call it mild, moderate dementia. They also have end-stage COPD on like 2 to 4 liters of oxygen, um, heart failure, or atrial fibrillation. Choose your own adventure. They have been admitted to the hospital every month for COPD exacerbation, and they've been in the hospital for like 3 to 5 days each time. So when they come into the hospital, their functional status might be 50% or 75%. Like their ability to do stuff is 75%. When they get that COPD exacerbation, that function drops. And that's why they go to the hospital because they're sick. So that's why that divot happens. They're in the hospital, and then however many days they're in the hospital tells you how wide it is because at the bottom is time. Right down here, it says time. So it's the number of days in the hospital, years, months, etc. So then that patient starts to recover because eventually you will be discharged from the hospital. So then that red line goes back up because of the recovery, the rehab, their functional status is starting to get better. We hope that they go back to their baseline, but the problem is we have dementia and we have other diseases. And so we're going to have a slow slope of decline. And just when we're trying to stabilize, we get another hospitalization. So that's the second divot. And so you're trying to gain ground, but you aren't because you're keep on going to the hospital and tanking. And so that's why the debt over time from the very beginning of this point to this point, that's like a 10%, 20% drop in your overall ability and function. So that's what I mean when I say it comes at a cost. And when I draw this, it's usually over 12 months. And so I say, where were you 12 months ago? Where are you now? How many hospitalizations have you had? This is why you're not getting better from rehab. I hope that helps.
Yes. Yeah. Thanks.
I'm going to skip this one for now. Lynn and I are going to put on a skit for you. The example is imagine you or you caring for somebody who is a 78-year-old person and they have mild to moderate dementia. They also have COPD. And they've been in and out of the hospital every 3 to 4 weeks in the last 3 months because they aspirated and got pneumonia. The pulse form says do not resuscitate. Don't intubate me. Don't send me to the ICU. You are a caregiver for this person. You wake up at 3 in the morning. And now you notice that this loved one of yours has a fever, is coughing. And then there's some labored breathing. You happen to be the daughter, son, uncle, spouse. Choose your identity. You're worried. It's 3 in the morning and you need medical attention. All right. So hopefully everybody got the scenario. We're setting the stage. Lynn is going to play the daughter, or you can play the wife, Lynn. Let me know which one you're playing.
Either one. I think that unless you're a medical person, or even if you are, that the anxiety is the same.
Yes, it is. All right. So why don't you be the daughter?
All right.
And it's 3 a.m. Who are you going to call, Lynn, first? Who do you think to call first?
Well, I'm going to call doctor on call.
Okay, so you're gonna call the doctor on call. Before you talk to the doctor on call, you're likely to talk to the nurse on call. So I'm gonna play the nurse on call, and I can kind of go in and out from being a doctor as well. It doesn't matter. It's the same kind of
Okay.
verbiage. All
So,
right, so ring, ring,
so I've
ring.
made that emergency call.
Okay, so I pick up the phone and I'll say, "Hi, I'm the nurse or doctor on call. How can I help you?"
Well, I'm calling regarding my husband who is 78 and he has moderate dementia, but he also has COPD and he is really sick right now. He was coughing, woke me up coughing. His breathing is very labored. He has a fever, and I'm really concerned.
Okay. I'd love to know what his name is and date of birth so I can like go look in the chart. Lynn, what I'm hearing you say is labored breathing, fever, coughing, and you are worried. I wish I could be there. Because it is in the middle of the night, your best bet is to go to the ER and get medical attention for your husband. They will be able to do everything more fast. I don't think that waiting in the morning for him to see the primary care or urgent care is a good idea.
So you're telling me I need to call 911?
Yes, ma'am. I think the best thing is to go to the ER. Okay.
Okay,
End scene.
I will do that.
Yeah. End scene. There is the moment anybody on this side hears shortness of breath, I'm worried, but really it's the shortness of breath. They're gonna be like, oh hell, there's nothing I can do for you on the phone. Like, go to the ER. It's 3 in the morning, right? People get scared. The
Can
the
I can I
physician people on this side get scared.
can I add something?
Yeah,
That person on that side doesn't even hear the dementia. All they
they
hear
don't.
is
They
COPD.
don't. They just hear about airway breathing and circulation,
Yes,
right?
exactly.
That's the ABCs of life. And so it's like, is airway okay? Are they breathing? Is their heartbeat okay? And if any of those are not okay, it doesn't matter what you have. Like you just got to go to the ER because there's nothing I can do. And I can't tell you to just look at him because he's labored. Like no one's going to do that. That's very scary. So that's scene one. All right, let's say that Lynn's family member is on hospice and this is happening and it's 3 a.m. All right. Ring, ring, ring. Hi, this is the nurse for hospice on call. How can I help you?
Hi, I'm calling regarding my husband who's 78. He's been on hospice for a few months now, but he is experiencing severe coughing and labored breathing. It woke me up. He looked really uncomfortable, and I took his temperature. He has a fever, and I'm really concerned about him. Is there something that you can do?
So if I knowing your phone number, your husband's Jason, is that correct? And you're
It
Lynn,
is.
right?
It is. Yes, thank you.
Yes, so my colleague just paid a visit to your house like last week and put him on my radar. Um, is he on oxygen already?
He's on 2 liters. I did increase him
Okay.
to 3 just because he's so short of breath.
Okay, that is a great move. I'm glad that you did that. Do you have one of those like pulse readers at home?
I do, and his
Okay, what does it
saturation
say?
is about 88.
Okay. As long as it's about 88 and above, you can stay at 3 liters. If it starts to dip down, you have my permission to just increase it to 4. Do you know that emergency kit that we gave you with the morphine and the Ativan? It's in the refrigerator.
Yes.
Okay, I want you to take the morphine out. Does he look agitated or anxious to you, or is it just the labored breathing?
No, he's anxious because he can't breathe.
Okay, we might have to use both then. There should be a dropper. I want you to pull out point 0.1 for each of them. I want you to
Okay,
just like drop it into his mouth.
I can do that.
And can he swallow?
Not very well.
Okay, so the liquid is fine. So you can drop it in, it'll just absorb. Um, how high is his temperature?
It's 102.
Okay. You can do one of two things. You could do ice packs and bring that temp down, or you can give him rectal Tylenol. I am going to drive my car to your house. I'll be there in half an hour to an hour.
Okay. All right. Thank you
You
so
have my
much.
number. I will be right there.
Thank you.
You're welcome. So hopefully you can see the difference between the two conversations. The nurse is not practicing outside of their scope. There are usually orders already in place for comfort. They just have to be reminded to the family member. Usually, hospice will give you all the materials you need in your home. The nurse has the ability to drive to your house. The nurse also has the ability to say, try those things, call me back in an hour and give me an update because they are on call 24/7. Is he going to get HS x-ray? No. Is he going to get antibiotics? Possibly no. He can't swallow. Do we think this might be it? It could be. And if the Ativan is called the anxiolytic, it's like Xanax. If the Ativan and the morphine can calm these things down and he can pass peacefully, he is at home right where he wants to be. If I, as the nurse, go to the house and he is still really symptomatic, I'm going to tell Lynn, hey, Lynn, we've tried everything at home. I think that we should take him into the hospice house. We have some more aggressive drugs that can keep him more comfortable. Do you think that would be okay?
Please.
So then he would go to the hospice house and then we would give him aggressive comfort measures. He either stabilizes, then goes home, or this is his natural end of life. And we are the right people to be taking care of him because it's not going to be in the ER where it's loud. We're not doing the chest x-ray only to find out that he's going to have this again. And that's torture, right? You're just treating the same thing over and over again, and you're just prolonging the suffering. And so those are the ways that this can kind of come down. Lynn is not left without help, but she has something that can help with the terror that she's seeing, which is the labored breathing, the agitation, the fever. All the things that she needs is in her home. And she has a practitioner, nurse, a medical person to support those decisions and be there. Questions about this, and also how did you feel about that role play? What is bubbling up for you all after that acting?
You can either put comments in the chat, or if you raise your hand, I'll let you talk, whichever you want. I think people are very quiet. Oh, here's one. Both my mother and my husband died on hospice, and it was so helpful to know that I could always call and get support and practical advice.
Yeah. If there isn't enough planning in place, then potentially Lynn's husband goes to the ER. They will do all the things except intubate him. They will do the chest x-ray, the EKG, they will draw blood, they will do all the things. And then if he survives the pneumonia, he goes home, but now his dementia is worse, and now he's had pneumonia. So he's gonna have to recover from that. And it could still happen again because he's not swallowing very well. So go ahead.
Other comments, total anxiety in the first example and comfort and support in the second. It's emotional, bringing back the memories of my mom passing while on hospice, but it's also helpful to remember the support that's given. Robin
Yeah, we
says,
apologize in advance for re-traumatization of anybody's experience. I, of course, picked this case because it's realistic, but again, wasn't meant to re-traumatize anyone.
another comment, it seems the hospice call was much kinder in caring for the patient's well-being. Hospice is amazing for the patient. I'm a huge advocate based on my mother's experience.
If the goals are in alignment with that type of answer, then you change jerseys. But if Lynn's husband said, I would like to live another month and see this grandchild being born. I would say go to the ER because that's the only chance that we could save you so that you could see the grandchild. But if Lynn's husband said, I've lived a good life, I am not afraid of dying, I don't want to die, but I also don't want to keep pounding away, then his goals are in alignment with comfort and natural end of life. So it always goes with what is the goal? Because hospice just doesn't just show up at your house and then you get it, and the doctors don't just order it for you. We have to ask permission and say, what are your goals? Is this something that you want right now? If not now, when? And so our heart breaks when a family member or a patient has not had this conversation and they undergo the chaos of scene one. They both end the same. So I think of it, I was going to draw a picture, but I think of life as a hike to the waterfall. And I think of death as not optional. Um, and so if we're all going to head towards the waterfall, I would like to get to the waterfall intact. I want to look good when I get to the waterfall. I don't want to be beaten up. I don't want to be gone through the ringer. I don't want to have taken the trail that had the brambles and the snakes and the landslide just to get to the waterfall. I could have taken the scenic route. And so sometimes helping people see the scenic route is what it takes. And then some people will say, no, I want to challenge myself. I'm a fighter. Let me take the hard route. And if the trail is open to you, you can take the hard route. If the trail is closed, then you have to look at different other routes and you still get to make your choose or your own adventure. But as a palliative medicine physician, if I'm your guide and holding the map to help you, I will always be checking in with you to say, are we still going in the direction that you want? And that'll probably be at every mile marker, just to make sure that you're not being bullied into going in that road, or your family's pushing you to go into that road, or whatever. I'm always going to be checking because it really is about you and how you're going to live until you die.
So another comment, in college, I helped a roommate watching her father on hospice. When it was near his death, I told her maybe she should tell him that he could go and you'll be okay. And she did, and he passed within 5 minutes.
If you're interested, having done this work for 10 years and change, parents often wait till their kids are gone and then they die. So you might go take a shower. You might go home from the ICU. You might go get coffee. This happened to my grandmother. She waited till my cousin went and got coffee, and then she decided, I'm going to die now. I don't want her here when I'm dead. And so I've seen that so many times. I've also seen what you just described, which is they need permission from the family. Because as a parent, I don't want my kids to cry. I don't want my kids to mourn for me. I want them to be sad, but not devastated. And so I don't want them to see me go because it'll be so tragic for them. But if they said to me, like, we'll be okay, um, you can go, I'd probably be like, oh, thank God they gave me permission. I need to get out of here. So that happens. That happens.
I think we got him. Oops. In scene one, where you call 911 and transit to ER, what happens if you tell the ER personnel you don't want a series of tests and procedures, but you want your person to be treated enough to reduce their symptoms, their fever and their breathing, instead of multiple tests? Is that possible?
It is. And you have to accept that you are tying their hands. You're on the team blue, and their goal is treat, cure, get rid of things, fix it. And now you're telling them, I just want like a little bit of that. First of all, they may say no. they may say, okay, you have the right as a patient to defer treatment. They won't be very happy because then they'll be like, why aren't you on hospice if you are not wanting these things and you want to be comfortable? We're not really the right people. We got some good drugs, but we're not really the right people to deliver that. Why aren't you all already on hospice? And if they don't say that to you, they definitely will be thinking it. So that answer is logistically true, emotionally not a great way to go. And Marilyn said learning what is changing for those with a memory disorder, the direction of treatment.
Yeah, that was that one that
Um,
we,
yeah, so I'm not a neurologist, but I will speak with what I do know. Um, the medications out there that we have right now, one part is to preserve memory. One part is to stabilize symptoms of agitation and behavioral disturbances. There is a new drug that you can do an infusion. It's usually run by the neurologist. Because it's new, because you have to sign a consent form because you have to consign consent when you do something. We're not quite sure yet if it's actually routine, but it is available and it is called an infusion. I forget the name of it, but Vancouver Clinic Neurology, Dr. Smith specifically, he sees patients and makes those recommendations. Other than that, we don't have like a radiation, a laser, a surgery. We don't have that. If you're so in this group here, we're talking like Alzheimer's dementia. If you're talking about Parkinson's dementia, there's something called deep brain stimulation. That is also something I wouldn't say that it's new, but it is one of the interventions that can reset or delay progression or remodel DBS.
That's my girl.
okay, think we can, oh, wait a minute. With
Uh-huh.
hospice, ER
Mm-hmm.
visits and extraordinary treatment choices are discussed. If they do not fit the boundaries for hospice admission, it's my understanding. I am wrong. It may call for a home visit by the hospice nurse. Has this changed?
I'm gonna have to read that really slowly.
Yeah, read that again because I didn't get it either.
With hospice ER visits and extraordinary treatment choices.
Oh, put a comma after hospice. With hospice, comma, ER visits and extraordinary treatments are discussed if they don't fit the boundaries for hospice admit.
Marilyn, why don't you unmute and ask the question? Because I think Lynn's right, but I don't want to be guessing. So you can unmute and just ask your question.
Okay, Marilyn, I unmuted you.
Lynn, can
There we
you
go.
hear
Yeah,
me?
Yeah.
we can
Okay.
hear you.
What I meant to say, and excuse me for not editing this correctly, but with
That's it.
hospice ER visit, with hospice, comma, you're right, Lynn.
Okay.
ER visits and extraordinary treatment choices are discussed. So in the scenario we are just talking about, I was asking if they do not fit the boundaries for a hospice admit, they talk about that. My understanding is right out front what you can do and cannot do, like going to ER, asking for blood transfusions, asking for this and that. My understanding is that a call to the hospice nurse with he or her doing a home visit would be the best choice. I guess. I just wanted to make sure that still was in place.
It's two things. I don't know if you're referring to the question before your question about showing up at the ER and saying, I want some things and no things. Is that what you're
Right.
referencing,
It
or you're
felt,
referencing the case?
yeah, it felt like we were going to a direction where people might be just going to ER. My perception and my understanding is that the first person you would call if you get into a crisis at home and they are on hospice, that the hospice nurse would make a call to the home to help stabilize or problem solve.
Yeah. So if you're referring to the question, and my chat doesn't let me go back up, there was a question in the chat about going to the ER and saying, I want these things. I just want comfort. I don't want these other things. The clarification is that patient is not on hospice,
Oh, okay.
and
That
they
makes
go to
sense.
the hospital
Okay.
and they say that,
Okay.
will beg the people receiving it to say, why aren't you on hospice if you're this selective about the menu? Because if you show up at the ER, the assumption is you want us to save you. You want us to
Right.
do stuff.
Right.
So if you show up and you're like, I just want the light menu, then they're like, why? Why don't you want the whole thing? Why are you going to let me not treat you and let me just stand by and not treat you, right? So that's what crosses people's mind. Now, if that same patient was on hospice and changed their mind, or Lynn changes her mind, and she's like, I know I'm on hospice, I know my husband's on hospice, but I, for some reason, had a change of heart. I don't want to call the hospice nurse. I want to go to the ER. She can go to the ER, she will revoke hospice, and ER will take care of her husband. Or she calls the hospice nurse says blah, 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 blah. And Lynn says, you know what? I think getting an x-ray might be a really good idea, and then get him on antibiotics. I think he can recover from this aspiration. And I just think we should give him a chance. We're still holding out for whatever. The hospice nurse will say, you have the right to do that. You need to revoke hospice, and we'll call 911 and your husband goes to the ER.
Yep.
That's not ideal, but it is legal to do. It's just not ideal because you shouldn't be yo-yoing. When you have a goals of care conversation with your geriatrician, your pulmonologist, your primary care, me, anybody, it should be very clear and it should be very solid. If you're still yo-yoing and saying, I just want to go back to the ER one more time, then you really didn't have a thorough goals of care, and you really wanted to still wear the blue jersey. You didn't really want to go to the orange jersey. And that is a part of suffering because now you're causing your family member to go back and forth because of the emotional reaction that is
Right.
happening.
Thank you.
What
Thanks,
kind of
Marilyn.
mom? If we are done early, I'd like to give you back your time so that you can go do more fun things than
Well, I have a bunch of more questions
okay.
if no
I'm
one
here.
else has more. I did want to make one comment following this case example is the discussion that we had related to an experience that I had recently. Went on vacation. Well, it was almost a year ago now. Was gone for 2 weeks, and when I came back, um, four of the loved ones of people in my group had died in that 2 months, or in that 2 weeks, excuse me, which was shocking enough. But listen to the descriptions of two of those people was this statement. I wish I'd understood where he was at. I just didn't get it. And in both of those cases, these individuals ended up in the hospital because of agitation that they couldn't deal with. And so 911 was called and they ended up in the hospital, a couple of different hospitals. And one of them, they were not allowed to see him because he was so agitated and he died in restraints. And the other one was also restrained, but the wife was able to be with him. And that would be one of the reasons that I talk ad nauseum about the FAST scale. And if you feel that your person is consistently between a 6 and a 7, that it's time to at least consider palliative care, and at 7 to consider hospice. So I just think that that's so important because number one, it was such a painful thing for these people to go through. That's no way to say goodbye. And of course, they did not do it intentionally, but it's going to be traumatic for them forever. And it makes me very sad because of that. So that's my story. So couple more comments here.
Lynn,
So yes.
this is Marilyn again. Those two situations, is it possible that good explanations were given, but they just weren't hearing it? Maybe not.
I think people hear things when they're ready to hear them.
Yeah, I agree with what you just said. Yeah.
And one of them was a fairly long-term group member. And the other one was a pretty new group member who, while she was extremely knowledgeable about Parkinson's disease, she didn't understand about the Lewy body dementia that often accompanies it.
Right. Okay. Thank you.
Yes. So a couple of other things. Susan says, in my experience as a hospice nurse, and Susan cares for her husband who has dementia, it often depends on how long a person has been on the hospice service. It's a learning experience for the family and the patients to adjust in the care ways. And then another person asks, what are the requirements before a person is admitted to hospice care? I've heard it's losing weight and it being consistent.
Under dementia, you have to get to 7C. If you aren't at 7C, but you are documenting, the practitioner is documenting a progression of decline that is expected to continue to decline in the next month, then they will take you on, hospice will accept you on a conditional basis because they need to see that continual decline. So that's a way that they used to take failure to thrive, but that wasn't a good deal. That was misused. So now if you're going to come in to hospice, you need the diagnosis. And if you couple that diagnosis with the clinician saying this patient has started to slowly stop eating and they're losing weight, then hospices will say, okay, that seems like a prognosis that is getting shorter. So we'll take you on. We'll watch you for 4 weeks. If you keep on declining, we'll keep you. If you become too healthy, we will graduate you. So that's just hospice. If you are going to hospice on another diagnosis like COPD, CHF, diabetes, etc., there are different criteria that the checkboxes fit that say this person has less than 6 months, and then you go into hospice care.
Susan made a comment that I think is important. It talks about beginning to rely on hospice personnel instead of going to the ER. It's a change in the way that you're thinking. So if anyone has other questions, you can put them in the chat, but I do have a stack here. Bear with me a second.
There was a question about voluntary cessation of eating and drinking earlier on.
Oh,
I
thank
want to
you.
make sure that we gathered all the bits and pieces for that.
So the person that asked that question, I think it was you, Gretchen. I'm going to just allow you to talk.
She said mainly answered, but yes, please clarify what parts you need.
Yeah, when I was hearing about it, they were talking about how they can voluntarily, and they would have it in their advance directive. But there was also, if you had your doctors, there were drugs that could help you with the pain that may be experienced with doing that.
Are they on hospice or not?
This is really forward thinking. My mom is already like planning her out, and she wants to have this in her advance directive, but her current doctor, she's moving up here to be up here. Her current doctor wouldn't allow that to be put into whatever plan she was talking about at the time.
I mean,
I
no
get
disrespect to your mom's doctor. Your mom, so this is not me talking as a doctor, this is me talking as a human being. I, as a human being, do have the right to write down my wishes on a piece of paper. This is what I want. The legality of it is I can want in one hand and I can in the other and see which one shows up. So in a legal document, I can say that I want to be cremated. I want to be comfortable when I die. I can tell my family in the process of my discussion, I want to voluntarily stop eating and drinking. I can ask for comfort measures, but I can't demand them and say, you, physician, clinician, will write morphine orders for me as I am voluntarily stopping eating and drinking. So it gets very technical, and that could be why the primary care said, I'm not going to do that. Because if she's not in a terminal way and she does, we call it VCED, voluntary cessation of eating and drinking. If she does that, but she's not having a terminal diagnosis, there really isn't anyone that's going to help her die. No one is going to give her comfort meds out of the scope of hospice or terminal illness. There's a law that protects us from doing that. So that's probably why the doctor pushed back. If your mom has a terminal illness and is on hospice and decides to voluntarily stop eating and drinking, hospice will give her comfort medications and support it, because there is a hospice in town that participates in death with dignity. And if a patient doesn't want to do death with dignity, the workaround is voluntary cessation of eating and drinking.
Yeah, her wish is not to go now. She's got Alzheimer's, and I think she's stage 3, 4-ish, maybe more 3. Her wishes, if she could write them and have them followed, would be to leave once she forgets who we are. And I know that's not gonna happen. And I don't think she can do the VSD or whatever it was called.
It wouldn't be voluntary at that point. It might be.
And I don't think she will remember that that's how she wanted to go eventually. So I think that's probably going to be off the table also. because she won't be of sound mind to like, she's not gonna, I think she'll just end up, going when, it's her time, but that is her wish to go once she forgets.
So sometimes we have to read between and through the words. And so if I wanted to read this in the most positive way, it would be someone saying, if I've lost my mind and I cannot recognize my family, I would like to die naturally from my not eating anymore. And during that time of my natural passing, I want to make sure that you make me comfortable or you support me in being comfortable. That will be the utmost positive regard interpretation of what she said. And then there's all these other interpretations. If there's any corroboration from your family, or if she's still of sound mind to tell you, she can clarify that. Because the voluntary cessation of eating and drinking when you're not sick is really hard to do. When you are sick, it's actually much easier to do.
Yeah.
And you're talking about like 2 weeks.
Yeah, I just don't think
So
she'll remember that's how she wanted to go, and we're not gonna, help her by. I was joking when I said I could show you a plate with some crumbs on it and tell you that you've already eaten, but that's not gonna happen. Um, but yeah,
see,
that is her
this is
wish.
why I like my job. I get to meet families that are like, they joke about the dry humor, such as the plate with the crumbs, and then we laugh about it. And we're laughing about it as we talk about quality of life and death. Um, and so people think we cry, but we don't. We talk about the absurdity and the jokes that we make to just kind of like normalize what's going on. That's inevitable. So thanks
I
for
was just
sharing.
going to say, you're normalizing death. Everybody is born and everybody dies. That's, yeah. All right. Last few minutes, a couple of questions. And of course, my phone goes away. Can palliative care programs help manage symptoms like agitation, confusion, and anxiety? And what about issues with pain, swallowing, or sleep?
The short answer is yes.
Okay. That may be all we need.
Okay.
How do I know what to ask a palliative care doctor or the practice? When should I ask for palliative care, for example?
Oh, okay. If you're facing caregiving distress, you're overwhelmed, you have a lot of balls juggling and you're dropping them, you find yourself making phone calls and people are not responding and you really could use an extra pair of hands to make those phone calls. When you're needing resources for a higher level of care and you're finding that the home is no longer safe for you or the person having dementia and you need to go to the next step. When you're faced with a decision tree, right? You're on the hike, there's a fork. And the fork is like, do this or don't do this. And you're like, I'm not sure. We can
I
help with
think
that.
that may answer this question. Can a palliative care practitioner help align treatment decisions with values and or goals, or even
Yes.
help us clarify or unpack our values or goals? Sometimes
Yes.
things get muddy in the day-to-day.
Yeah, we one of the slides that I was gonna show you was the decision tree. And I do this in my practice. I have a big bulletin sticky note that I put on the wall and I start drawing the picture. And I said, okay, we're hiking. What's one pathway? What's one option that they've given you? What's another option that they've given you? And then we write what the trail looks like. If you go do the colonoscopy, this is the pro and this is the con. If you don't do the colonoscopy, this is the pro and this is the con. And then we start seeing all these roads intersect And then I'm like, there's also the scenic route. This is what it looks like. Um, and so as a tour guide, I know the trails, and then I have to ask really good questions of you and the family and the patient to say, what are you looking for? What are your goals? What's important to you? What are must-haves? What are must-nots? And then I recommend which trail matches what you just told me.
What conversation should we all be having about advanced care planning, knowing about this dementia diagnosis and the common trajectory?
Yeah. I wish that I had it with me. There are 6 questions designed by Dr. Atul Gawande, who he's a neurosurgeon, operates out of Harvard. He created a serious illness guide conversation tool. And there are 6 questions about quality of life. And so at this point, it would be good to ask these questions of yourself and of your family member. The first one is, as your disease gets worse, what are you hoping for? What is important to you? Second question, as your disease gets worse, what worries you? What fears do you have about the future with your disease? Number 3, what gives you promise and hope about the future? What makes you wake up every day and face another day? What are the bright spots? Next question is, how much are you willing to go through for the chance of more time? And then the last question is, does your family know your wishes? Would they be surprised by any of your answers up to this point? Because if they are, you need more conversation. If you don't think that they would be surprised, go select your power of attorney so that that person can be the recorder and talk to the blue or orange team about what's up. So all those questions didn't really talk about death. They talked about, like, how do you want to live? What's important to you? And people say some really amazing things. And again, that's one of the better parts of my job. I get to kind of see people for who they really are and not just a diagnosis. I get to see the person that enjoys gardening, the person that has like 10 guitars, the person who has 3 acres and only mows, a quarter of it. There's just so many different colorful lives that come in when we talk about how they want things to be. And I guess, like, I have control issues. I would like to design my end of life. I would like to design my trail. I don't like people telling me what to do. Oh, you're so welcome, Judy. And everybody. I hope you have a good evening. I hope that the journey that you're taking with your loved one is, comfortable, safe, scenic. Sometimes I wish that you have boring trails because sometimes the exciting trails are just way too much. But yeah, I'm thinking of you all in a special place of my brain that I hold for dementia patients.
Thank you so much. So I will make sure that everybody gets a copy of those slides when you send them to me. And do you have a copy of the 6 things from Gawande? I have his book and I can find them, but if you
Yeah, let me send it to you in the email.
okay,
They're easy to find. But the 5 Wishes is also a really good resource.
yeah, I really like it as well. Thank you so much.
All right, good night, everyone.
Bye-bye.
Bye-bye.